All right, let's get right into it. As a trainee, one of the most common things you're going to hear is a cardiac murmur. And yeah, it can be a little intimidating, right? This subtle sound that carries so much diagnostic weight. But what if you had a clear, simple framework to tackle it every single time? Well, that's exactly what we're going to build right now.
So this is the moment. You're with the patient, you put your stethoscope on their chest, and there it is, that little whoosh or rumble. And the first question that just explodes in your brain is, okay, now what? Is this something to worry about? Do I need to order a test? Or do I just make a note and move on? Let's figure that out.
So, the first and probably most critical step is learning how to triage with your ears. See, not every murmur is created equal. Some are totally benign, just innocent bystanders, really. But others are waving a giant red flag that points to some real structural heart disease. The key is knowing which sounds are just noise and which ones are screaming for a closer look.
Okay, so this slide right here, this is basically your cheat sheet for those red flags. Think of it as your first filter. Is the murmur loud, like a grade 3 out of 6 or higher? You investigate. Does it last through the entire heartbeat or show up late? You investigate. And you know, the rules for diastolic and continuous murmurs are even easier. They always get a workup, period. And of course, if the patient has any symptoms, shortness of breath, chest pain, you name it, it doesn't matter how faint the murmur is, you've got to investigate. These are your guideposts.
So you've identified one of these suspicious murmurs, and it is so tempting to just immediately jump to ordering a whole bunch of fancy, high-tech imaging. But hold on a second. The best clinicians out there know that the most powerful diagnostic tools are the ones you carry with you every single day: your hands, your ears, and your brain.
Let's just pause and let that one sink in for a second. This idea is the absolute foundation of everything we do. Before you even think about an image or a lab test, the story the patient tells you and the signs you find on your exam, that's what really matters. That's where the real diagnosis begins. And this slide really gets to the why of it all. A really good history and physical, it does more than just give you clues. It's what lets you be a detective, not just someone putting in orders. It stops you from ordering a shotgun blast of unnecessary tests and helps you pick the right next step. It's all about being focused and efficient for your patient.
Okay, so you've done your homework at the bedside, you've confirmed your suspicion, and now it's time to actually get a look at the heart. So let's talk about our first and most important imaging tool.
So let's talk about the TTE, the transthoracic echocardiogram. This thing is your absolute workhorse. It's just a non-invasive ultrasound of the heart, but it gives you a truly incredible amount of information, all without any risk to the patient. For pretty much any murmur that meets those red flag criteria we talked about, this is going to be your first-line test.
And the amount of data you get from a TTE is just amazing. It's not just some fuzzy picture. It's a full-on assessment. You can see the size of the chambers, how well they're pumping. You can look for wall motion issues that might mean a past heart attack. And, most importantly for our murmur, you get to look directly at the valves. You can see stenosis, regurgitation, even signs of an infection, like endocarditis. It is a fantastic, comprehensive first look.
But what happens when the TT gives you a picture that's maybe a little incomplete, or when you need to see certain parts of the heart in much, much higher detail? Well, that's when we have to level up our imaging and call for a deeper, more focused view.
And that brings us to the TTE sibling, the TEE, or transesophageal echo. This slide breaks down the difference perfectly. The TTE is non-invasive, it's our first choice. The TEE, on the other hand, is invasive. The ultrasound probe actually goes down the patient's esophagus. So why on earth would we do that? Well, it's all about location. It gets the probe right up against the back of the heart, giving you an absolutely unparalleled view of the structures back there that can be really tough to see on a regular TTE.
So the bottom line is this. You order a TE when you have a very specific, high-stakes question. Are you worried about an abscess from endocarditis? Do you need a crystal clear look at how a prosthetic mitral valve is working? Is there a blood clot hiding out in the left atrial appendage? For these kinds of detailed questions, the TE is the definitive test. Now, let's just zoom out for a second. This table is your high-yield summary, a great little cheat sheet. TTE is your mainstay, your go-to. TEE is for that detailed, superior look at very specific things. And don't forget cardiac MRI, or CMR. That's your best bet when you think the problem is with the heart muscle itself, like hypertrophy, because it gives you amazing analysis of the tissue. Just remember to ask yourself, what's the question I'm trying to answer? That'll tell you which test to pick.
Whew.
We have covered a lot of ground, from the simple physical exam all the way to advanced imaging. So now let's pull all these pieces together into a simple, actionable game plan that you can use every single time you hear a murmur.
And here is that framework. It's a simple 4-step pathway. First, you start at the bedside. You identify those red flag characteristics. Then you use your clinical skills. You assess the patient with a full history and physical. Only then do you move to technology. You image with a TTE. And you only escalate to something more advanced, like a TE or a CMR, if the picture is still fuzzy. You see, it's a logical, efficient flow that always starts with the patient.
Look, if you take only one thing away from this whole explainer, let it be this. Don't just order tests blindly. Think. What does the clinical picture tell me? What is the exact question I need this imaging study to answer for me? That kind of thoughtful, targeted reasoning is what separates a good clinician from a truly great one.
So, the next time you put that stethoscope on a patient's chest and you hear that murmur, that feeling of uncertainty, it's gone. It's replaced by a clear, confident plan. You have the framework now. The only question left is how are you going to use it to help your next patient?